most of you joining today know what fibroids are, but they're non-cancerous tumors. So a lot of time patients ask, can my fibroids become cancerous? The answer is no, but certainly somebody can have cancer within the uterus in addition to fibroids. So anytime someone's having new onset abnormal bleeding and someone who has history of fibroids, but something has changed, a biopsy is usually required. Now, what are the symptoms of fibroids? So symptoms are going to vary a lot based on location. So if we look at this picture here, and you have, here's the uterus, the inside of the uterus, which is the uterine cavity. Can you see my?
No, so we're still on the first page. So we want to be on the third. The first slide is what we're seeing.
Oh, you're still seeing the first slide?
Yes.
But I'm already on the third slide. How do I move on from that? That's weird. Should I stop sharing?
Bear with us. Let's see. Okay, perfect.
All right, so can you see the arrow?
Yes.
Okay. All right, so here's the uterus, uterine cavity, and this is where pregnancy will sit. This is where the period comes from. So it's really the shedding of the lining of this uterine cavity is what a period is. So anytime you have fibroids that are near or inside the uterine cavity, you're going to have abnormal bleeding. When you have fibroids more on the outside of the uterus, or like this one here, the symptoms are going to be more like bulk symptoms, which is when someone has pressure, pelvic pressure, frequent urination or unable to urinate, or constipation or back pain, or actually seeing the belly protruding. So that's those other outside fibroids grow with time. But typically the outside fibroids are less symptomatic. So they create less symptoms when they're small, because really you can't really feel them. Again, the fibroids that are near the uterine cavity or submucosal would cause more bleeding and more problems. Risk factors, 80% of African-American women will have fibroids before the age of 50. So they are very common. So when we treat women with abnormal bleeding, let's say without previous diagnosis, fibroids is what we always should consider, especially in African-American women. What is the best way to diagnose fibroids? Physical exam is not helpful. Okay, so I've seen many patients who were going to the OBGYN year after year, and they had no idea they had fibroids. So even when you're getting pap smears or getting a manual exam, you know, unless the patient is extremely, extremely thin, and unless the fibroids are very big, you're going to miss fibroids. So it may not be a bad idea when we see a patient at high risk for fibroids. So an African-American woman, let's say in her, you know, in the reproductive age range, it's even if they don't have any symptoms, it may not be a bad idea to get a baseline ultrasound, because ultrasound is most commonly used for diagnosis. It's a very quick and easy way to diagnose the problem. A lot of OBGYN offices have an ultrasound machine there because they do a lot of obstetrics, like scanning pregnant patients. So it should be easy to do a quick scan, find out if you have fibroids, great. MRI is often not needed. A lot of times it is performed, especially when interventional radiologists get involved and are considering uterine fibroid embolization. We'll talk about that later, but MRI is really not necessary. The ultrasound typically does the job in terms of fibroids diagnosis. All right. Sorry. Yep. Now, fibroids and fertility. So there was a question previously asked, you know, is it can fibroids prevent pregnancy? Absolutely. Okay, so fibroids can definitely be an issue with pregnancy, with getting pregnant and staying pregnant. So fibroids in the uterine cavity. So here's a fibroid that's hanging right into the uterine cavity. There's a fibroid protruding into the uterine cavity. So both of these fibroids are a problem, all right? So if you are considering getting pregnant, even if it's not now, let's say, you know, sometime in the future, and you have these two fibroids, even if you feel like you don't have any symptoms or your symptoms are pretty mild, you really need to think about getting these fibroids removed, even if they're not large. Actually, the smaller they are, the easier it's going to be to take them out. And that can be done hysteroscopically, which we go in with a thin camera through the cervix into the uterine cavity and just remove these fibroids when they're small, okay? If you wait and they become very large, then the approach changes. And then fibroids can also cause blockage of the fallopian tubes. So you may say, well, why I'm not getting pregnant. I don't have any, fibroids in the uterine cavity. Or maybe your OBGYN might say, you don't have any fibroids that are protruding into the uterine cavity. I don't know, you have a fibroid on the outside of the uterus, but I don't think it's a problem. Think about the fallopian tubes. So both of your fallopian tubes might be blocked by the fibroids. Easy way to check would be to do an HSG, or it's a hysterosalpingogram. It's an X-ray with a dye test that checks the tubes. But just again, keep in mind that fibroids may not only interfere with the uterine cavity, but also may cause blockage of the tubes. Fibroids can interfere with egg retrieval. So let's say you're going through fertility treatments and you're doing IVF. If you have very large fibroids, and for some reason your fertility doctor has not suggested that you have them removed, because again, they usually are only concerned with the uterine cavity. So if your uterine cavity is free from fibroids, they may say, yeah, you have large fibroids, but they're all on the outside of the uterus, and we don't really care about that. But those fibroids may actually interfere with egg retrieval. So if you have large fibroids near the ovaries, when they go in through the vagina to retrieve eggs, they may not actually get to the ovaries, or they may not get to all the follicles where the eggs sit. And so your egg retrieval may not be as successful as it would be if you didn't have those fibroids. So it's something to think about, and to ask your doctor, really, should you have those fibroids removed so the egg retrieval process would be easier and more successful? Because remember, you're paying money for IVF. Now, let's say you got pregnant and maybe you didn't know that you had fibroids, or maybe you knew, but your OBGYN or your fertility doctor say that, it's really, they're outside, they're not, don't worry about it. Now, what can happen to fibroids during pregnancy is the fibroids can grow during pregnancy. So they can rapidly enlarge, and they can cause pregnancy loss. The most devastating thing would be late pregnancy loss, meaning that, something like second trimester before the baby is viable. So I've seen patients that came to me after they lost their pregnancy at, let's say, 22 weeks, and that there's nothing you can do, right? It happens and it's horrible. But something like this with the uterus filled with fibroids, definitely preterm labor at a gestation time where the pregnancy is not viable, so the baby cannot live outside of the womb. If the delivery happens, then that's it. And then just preterm labor, let's say at 28 weeks, right? And all the different complications they can come from that, where the baby is premature. And then most patients with large fibroids will require a C-section, a cesarean delivery. So if, let's say, you're a patient who declined to do fibroid removal surgery because you didn't want to have a C-section, think about the fact that you're probably going to end up with a C-section anyways because of these large fibroids. And just in general, at least 30% of labor ends in a C-section. So unfortunately, it's one of those things we cannot control. And I think it's important to just focus on what's best for the pregnancy and for the baby, rather than focusing on just one aspect, such as the mode of delivery. Can
we take a pause to take a couple of questions?
Yeah.
So Latoya here asks, what causes fibroids and why are African-American women more likely to have them?
Yeah, we don't know why, women have fibroids. We know that they're estrogen-dependent tumors of the uterus, but we do not know why certain ethnic groups are at higher risk. there, but again, they're estrogen driven, but there's not been a specific link to why African American women are at higher risk. Also Asian women as well.
On the same line of thought process, Evelyn asks, I'm menopausal. I am in menopause and my fibroids are causing back pressure. Constant urination and belly protruding, but my GYN doesn't want to remove them. Is it true that African American women are mythified that we can handle pain better than other race?
I think, and that's, you brought up great points. So first, I'm just going to address so what you're experiencing is bulk symptoms. So that's perfect example that right after menopause, periods stop, right? So the fibroids are not causing any issues with bleeding, but because they're large, they're going to continue to cause pressure in the pelvis. And the organ that sits right in front of the uterus is the bladder. And the organ that sits behind the uterus is the rectum and your spine. So back pain, pelvic pressure, and constant urination and the belly protruding are the classic symptoms of just large fibroids just sitting there, right? Why doesn't the OBGYN want to remove them? I have no idea, honestly. So that's not appropriate, right? And this is a great time to say, okay, she doesn't, or he or she doesn't want to treat me, I'm going to go to somebody else. Is it true that African-American women, that there's the idea that they can handle pain better than others? I'm not sure. I think it's definitely, when it comes to fibroids, because they're more common in African-American women, it's almost like normalized. Oh, you have fibroids, so does this person and this person, and your whole family probably has fibroids. So it's like it becomes part of a norm. And I don't know what part of the country you live in, but I think especially areas that have fewer African-American women. For example, I spoke with a patient from Oklahoma last week, and she was completely mismanaged when it came to fibroids, and it was clear that her OBGYN probably doesn't treat a lot of fibroids, and she does not want to treat them. She doesn't know how to treat them correctly, and so she was given the wrong recommendation, and it's not that she thought that the patient could handle pain better, but it's not her area that she wants to deal with. So I think you just have to be your own advocate and seek treatment from somebody who's an expert. And that will help you in many ways. One, that person will understand you much better because they treat patients just like you all the time. And two, when it comes to treatment, they're going to recommend more appropriate treatment for you, what is right for you in your situation. And also, if you're going for surgical treatment, there's many studies that showed that there are fewer complications when the surgery is done by a skilled surgeon, by someone who has a lot of experience versus someone who does very few surgeries. So you just have to tell that OBGYN, okay, you're not listening to me. And you don't have to, you can be polite, or you can just say thank you very much and schedule an appointment with somebody else. So unfortunately, I definitely see that there's a lot of delay in care. And for sure, I think African-American women are affected more because, again, it's just normalized. Oh, you're African-American, you have fibroids. It's, something that's, again, part of the norm. I definitely see more patients who are Caucasian who are coming in with smaller fibroids. And as soon as they're diagnosed, they're freaking out and wanting to have, something done about it because maybe they've never heard of fibroids, or they think it's like something very unusual, where an African-American woman may be less react less to such a diagnosis because she may know people in her family or her friends who have fibroids. And again, there's not that type of reaction. And if their OBGYN is not encourage them to seek treatment, then there may be a huge delay in care.
Thank you.
Sure. Sorry, that was a very long-winded question.
No, that was great.
Okay, I can read the rest of them. Is there any correlation of fibroids and hernias? Certainly, if you have fibroids that are large enough, they can push and protrude the umbilical hernia, which is a hernia on the belly button. So a question from Evelyn's question: what should be done if there's continuous bleeding and spotting? I was told only hysterectomy can be done. I mean, it depends on the situation, how big, if we're assuming this is a fibroid, again, a biopsy may be necessary to make sure that the bleeding and spotting is not coming from something else. 100% it should be done if a woman is postmenopausal. If it is found that it's from a fibroid and it's a small fibroid, it can be removed from the uterine cavity hysteroscopically. You don't have to have a hysterectomy, but it really depends on the size and the number of the fibroids. Let's see.
We got them.
Okay, this is just a comment.
Yes,
Okay.
no, I think this is a good time to.
Okay, sounds good. Okay, so I'm just going to jump back in. All right, so medical management, hormonal management. So these are treatment options, and some of these are not, you know, I call them treatment because they're really not treating the fibroids, they're treating the symptoms. Uterine fibroid embolization, ASESA, which is laparoscopy with radiofrequency ablation of the fibroids, and then surgical intervention, myomectomy, which is just a word for removing fibroids, and hysterectomy is a word for removing the uterus. But in both of these cases, you know, it's surgical treatment of the fibroids, but by removing them. All right, so treatment, which is medical management. So this is all, think of it as symptoms, right? So the birth control pills, the patch, the IUD, the Implanon, the Depo-Provera, which is an injection. So none of these are making your fibroids go away, okay, or stopping them from growing. You're just being prescribed this to control the symptoms, right? So these traditionally, they're designed to prevent pregnancy because they're contraceptives. They may help with abnormal bleeding, but as sometimes that actually leads to delay in care because, you know, the OBGYN will prescribe the birth control pill, the bleeding is controlled, all is well, we forgot about the fibroids, but the fibroids are going to continue to grow because they're estrogen-dependent tumors, and ovaries make a ton of estrogen. So as long as a patient is premenopausal, the fibroids are going to continue to grow. After menopause, they're just going to sit there. They're not going to keep growing, but they will sit there and potentially cause problems. Fibroids do not shrink from birth control pills or implant or patch or IUD. So again, it's just, I don't want you to think that because now you've solved the issue of heavy bleeding with the birth control pill, that the fibroids can be ignored because again, they will continue to grow. And typically the longer you wait, the more potential complications you may have with addressing the fibroids. Oralis and Myfembree Lupron. So Oralis and Myfembree, those are kind of oral versions, let's say, of the Lupron, which is an injection. And these block estrogen production. So they sort of put you into temporary menopause. These in general, with short-term use, they're not dangerous medications, but they can have pretty, you know, unwanted side effects. Hot flashes, night sweats, those are the menopausal symptoms, can worsen depression with prolonged use, can cause bone thinning or osteoporosis. They can, over time, reduce the size of fibroids, but you have to make sure you understand it's not going to be a massive reduction. So if you have a fibroid the size of a watermelon, you're not going to end up with a grape. So this is just, again, a Band-Aid that's not going to stay on forever, right? So eventually you're going to have to really address these fibroids, and effect can take several months. So, I mean, do I agree with prescribing Myfembree or Orilissa for fibroids? I mean, if let's say the patient is going to have surgery, but she's extremely anemic, and this is just a temporary way to stop the bleeding, to stop the periods, that's okay. If we're just kind of, again, delaying care and there's no plan in sight, then that should not be used like that. And it is not necessary prior to fibroid removal surgery. So let's say if your doctor told you, you have to go on Myfembree for 6 months because we want to shrink the fibroids so that we can safely take them out, you don't have to do that. You can just have the surgery if you're otherwise ready to have the surgery. Uterine fibroid embolization, very common treatment for fibroids, in my opinion, it's overused, and I'm sure my opinion is not the only opinion in the world. So ideal patients with uterine fibroid embolization, someone who does not want to get pregnant ever, okay? So if your doctor tells you that you can have uterine fibroid embolization and you want to get pregnant in the future, you need to tell them no thank you, and move on to somebody else, okay? Should not be used. No matter, yes, have there been patients that gotten pregnant after uterine fibroid embolization? Absolutely. But that doesn't mean that it's the right thing to do. If you're someone who is, in your 30s, a UFE is not right for you, again, because of the potential for pregnancy in the future. If you know 100% you don't want to conceive, maybe you want to do UFE. Now, and that's short for uterine fibroid embolization. Another thing to remember is that the fibroids do not go away with uterine fibroid embolization. So if you have very large fibroids and you, like one of the patients that had a question, or one of the women that had a question, I think it was Evelyn, Evelyn, who is postmenopausal, doing embolization is going to be completely useless because those large fibroids causing those bulk symptoms are going to stay large fibroids causing bulk symptoms. It's best to use it for abnormal bleeding. And again, on small to medium-sized fibroids, that's going to be your best results. If fibroids are large, over 10 centimeters, don't waste your time. Another very important point is that studies show that up to 37% of patients experience decrease in ovarian function. What does that mean? Ovaries produce hormones. And that is how, and those hormones are directly involved in the ability to get pregnant. So if during the embolization, which is this picture, so it's either done through the groin or through the wrist, and there's a catheter that's placed, and the little beads, little particles are injected through that catheter to block the blood flow to the fibroids. So during that process, it's possible to get some of those beads into the ovaries as well, because the ovaries are connected to the uterus, and that can, again, affect ovarian function. So even, let's say, if menopause is not as much of a concern, the biggest concern should be reducing ovarian function in terms of fertility, right? So for fertility purposes, not only can you not be in menopause, but you can't even be with elevated hormone levels that are premenopausal. All right. So again, that is why you do not do this procedure in someone who wants to get pregnant. And then, again, with large fibroids, you're only going to see minimal decrease in size. So if you have a giant uterus the size of a, watermelon, do not do embolization. You're not going to be happy. A year later, you're going to have the same issue. And I'll give you an example of a patient who that happened to. Acessa, another procedure, it's less common. The reason for that is because many insurance plans do not cover this. Okay, so it's not paid for by the insurance, so you would end up paying out of pocket. They're only, there are not a lot of places that do this, and so you're going to end up spending your own money and traveling. And what you should know is that, again, fibroids are not removed. It is laparoscopy, so this is surgery, right? So it's not non-surgical, it's surgery. You're having laparoscopy, you have at least 3 incisions. One incision is for the camera, one incision is for the ultrasound probe, and one incision is for this handpiece for the radio frequency. So the handpiece goes into the fibroid, and then, applying radio frequency to kind of make the fibroid die. So the fibroid degenerates, and then it just stays there. Okay. Again, not effective for large fibroids. So if you have very large fibroids, if you have bulk symptoms, this is not the right procedure for you. If you're trying to get pregnant and the fibroid is actually in the way of pregnancy, again, not the right procedure for you because the fibroid is still going to be there. Maybe it won't get bigger, but it's still going to be there. Myomectomy means fibroid removal. So now we're talking about surgery. The LAM procedure is the procedure that we do. It's a minimally invasive fibroid removal surgery, which is safe, And it actually is the best option for patients who want fertility, right? Because we're actually removing the fibroids. And immediately, whether you have bulk symptoms, which is frequent urination and pelvic pressure and back pain, those go away right away because we're actually taking out these tumors. And then if you have abnormal bleeding, the same thing, we're taking out the fibroids. And it typically, most of the time, it's safe to get pregnant in 6 months after the surgery. Why is it 6 months? Because the uterus has to heal. Recovery for you to go back to normal activities, 10 to 14 days. It's outpatient, completely outpatient, no hospital stay, and is safe for large fibroids. So someone asked a question whether the surgery, let's say minimally invasive surgery, can it be done for very large fibroids? I have a fibroid that's 11 by 9 by 9 centimeters. Yes, it can absolutely be done, whether it's one fibroid or multiple fibroids. And also with this procedure, it doesn't matter where the fibroids are located within the uterus, whether they're hanging on the outside of the uterus or they're inside the uterus, all of those fibroids can be removed. How does it compare to other myomectomy techniques? So what are other myomectomy options? So your doctor may have offered you open surgery, which is the standard for fibroid removal surgery, but you do not have to have it that way. It's just most OBGYNs do myomectomies with a large open incision. So this is like a C-section cut, right? Or maybe it could even be an up and down incision. So I would say seek second opinion if that's the case. Minimally invasive approaches could be robotic. So that's a very common approach, robotic myomectomy. The issue with robotic myomectomy or with standard laparoscopic myomectomy is that typically the deeper fibroids do not get removed because they're smaller and they cannot be found with a laparoscopic or robotic instrument. So typically robotic and laparoscopic myomectomies are done for external fibroids. The fibroid size is going to be a limitation there. So with very large fibroids or very numerous fibroids, robotic or traditional laparoscopic is not going to be an option. We actually did a study that was published in, when was it? I'm sorry, 2019, I believe. And this in the JMIG, which is a journal of minimally invasive gynecology. It's a big peer-reviewed journal. And we compared different types of myomectomies to our technique. So it was 1,300 patients out of a single hospital. So between the years of 11 and 13, we collected data, right? And took all the myomectomy surgeries that were performed in that hospital, excluded the really inexperienced surgeons because we didn't want their results to kind of alter the data. So took only high volume, very experienced surgeons so that we can really compare the techniques rather than surgical skill. And we found that with the LAM approach, there's lower blood loss. So there's less bleeding during a surgery, which is very important because a lot of patients we see already have low blood count or anemia. Faster operative time. So the surgery time was actually faster. There were shorter amount of time that they were under general anesthesia. And then there were fewer complications. So what are potential complications with myomectomy, right? So there's increased blood loss. There can be injury to nearby structures, which is very rare, but it can happen. There can be infection, right? And then more fibroids were actually removed. So compared with other minimally invasive techniques like robotic or standard laparoscopic approach, there were more fibroids removed and deeper fibroids removed with the LAM approach. So again, it is really the best approach for someone who's trying to conceive and who has symptoms or is thinking about, having pregnancy in the future. Now, this is a true story. Just recently, the surgery was done June 29th. So it's someone who's from out of town and reached out to us because her OBGYN recommended open surgery. She is 30 years old. She has one child, but wants to potentially get pregnant in the future. And what was happening is that she knew she had fibroids, but she had all of a sudden severe pain that actually drove her to the ER. And they did an ultrasound and saw a very large fibroid. And what can happen sometimes with large fibroids is that when they grow very fast, they, what we call, outgrow their blood supply. So their blood vessels feeding into this fibroid, and the fibroid is large, and all of a sudden it's not getting enough blood or food, nutrition. And so the fibroid starts to die off, kind of the same way that embolization works, right? What the embolization does, it cuts off the blood supply to the fibroid. So this can happen spontaneously, and that can lead to a lot of pain. And of course, because the fibroid was very large, we don't want to, again, leave it there, especially because a patient wants to get pregnant. And so she traveled to Maryland, and we did the LAM procedure and took out the fibroid. So this is actually, this whole thing is one fibroid, and then she also had another small one. But that's, this is, what is it? This is a 6-inch ruler, and this fibroid is removed in segments because we're using a small incision. We do not use paramorcellation. We just use 2 small incisions, one at the top of the belly button, it's 1/4 of an inch, and then one in the bikini line is about 1.5 to 2 inches.
Dr. D.
Yeah.
Can we take a pause here and we have a lot of questions that are coming in, so just take a break and dive into them.
Yeah.
We can start, I believe, where did we stop? We have a question. As you can see, a lot of them have been. So we have Kamishka. Forgive me if I mispronounced that name, but what about, do you see that question about tranexamic acid?
Yeah, TXA. Yeah, so tranexamic acid, sorry, I forgot to mention that one, but that's only to control the heavy bleeding. So it's not a birth control pill at all. It's not a hormonal pill. What it does, it controls the bleeding during the episode of bleeding. So when you're prescribed birth control pill, you're taking it every day, whether you're bleeding or not. I mean, if you only took it during bleeding time, it would not work, right? You have to just be continuously on it. For the tranexamic acid, you take it at the time of the bleeding, kind of like for headache, when you take a Tylenol for your headache, same thing. So we actually also use it sometimes during surgery to help with excessive bleeding during a myomectomy. So, but it's not a solution, right? So I would say if you're taking TXA or tranexamic acid, that's a sign you need to do something about your fibroids, right? So it's already gotten to this point. So this is only really prescribed with really excessive bleeding. So as far as the natural dietary remedies, so think about this. Fibroid is a tumor, so only 2 things make it work, make it grow or not grow: blood supply and estrogen. All right, that's it, nothing else. So one way to stop the fibroid from growing is either cut out the estrogen completely, so you would have to go into menopause, or cut off the blood supply to the fibroid. So that would be embolization, right? Again, the fibroid would still be there, but if we're talking about, non-surgical way of helping either reduce the size or stop the fibroid from getting larger, would be only to target those 2 things. Even though there are some foods, right, that have estrogenic properties, if your ovaries are working, there's no way you're going to be able to reduce the production of estrogen. So cutting out tofu is really going to be a drop in a bucket because your ovaries are producing a ton of estrogen. So it's just not going to be helpful. And again, this a lot of times will lead to delay in care, right? So a lot of the patients I see come to me because they said, okay, I've been diagnosed with fibroids 3 years ago, and I tried to do things naturally, but here I am because they've grown, it didn't work. I'm not trying to discourage someone from being healthy and eating healthy diet. That's not what I'm doing, but I just want to be realistic and so that patients can understand that what will truly work for them. And maybe if they're small fibroids, of course, that's not an issue. But if your fibroids are big enough to where you're already being recommended surgery, I would say waiting a couple more years to try to deal with things naturally is probably not the right approach. Why are women in perimenopause denied myomectomies? I've been told by 2 doctors that when you're no longer planning to get pregnant, the only choice is a hysterectomy for the removal of large subservical fibroid, even though my organs are all healthy. Great question. Okay, so that's going to also vary. So typically, you know, sort of an ideal world, myomectomies are designed for someone who's trying to preserve the uterus for fertility. The reason for that is because inherently myomectomies are much riskier procedures than a partial hysterectomy. Although it sounds sort of not rational, right? Why would you're only taking out fibroids versus you're taking out the whole uterus. Why is it less risky? The partial hysterectomy is less risky because you're taking out the uterus as a whole, right? So you're going in, you're cutting off the blood supply to the uterus, and then you're detaching it. I mean, I'm making it sound very simplistic, but that's basically what you do. For fibroids, when we're dealing, you know, with very large fibroids or multiple fibroids, you have to go in, take out the fibroid or fibroids, and then reconstruct the uterus back together in the way that it does not bleed, it doesn't get infected, you know, so there are more potential intraoperative complications, which means complications during surgery and post-surgery complications that are typically higher in myomectomy than with a hysterectomy. Recovery is also easier with a partial hysterectomy than a myomectomy. We're comparing minimally invasive both. So if I make same incisions, same size, same location, but in one patient, I take out just the fibroids and in one, the whole uterus, the hysterectomy patient is going to recover much faster and they're going to have an easier time. Okay, so that the first few days, myomectomy is going to be much more painful than after hysterectomy. So that may be the reason, right? So if, and I myself sometimes tell this to the patient. So if someone who's, let's say, 45 years old and has very large fibroids, I tell them it's the surgery has to, the risks cannot outweigh the benefits, right? So if the risk of surgery is over here, but the benefit is that just you want to keep the uterus, but there is, you're not going to be using it for anything, then we don't do it, right? So, but if it's a, you know, one fibroid and somebody who's 45, and I think from my professional standpoint that the risks are going to be very similar, then I would do it. So it's not, again, everybody is going to be different. So I don't want to say we never do myomectomy in someone who does not want to get pregnant, but who's premenopausal. No, I have done plenty of myomectomies on patients who I knew were not planning on getting pregnant, but I would only do it if the risks were not greater. Yeah. Okay. Okay. Yeah. So this is a great example. This is somebody about UFE. So let me just, actually, no, this is good. So I had UAE, which is same thing as UFE, uterine fibroid embolization. In 2019, for a large fibroid, it shrank and now it's growing again and mostly bulk symptoms. I had surgery for related umbilical hernia. I'm menopausal. Is there any evidence that HRT will affect fibroid growth? Okay, or that a stronger progesterone regimen is better. I'm considering surgery, but would like to avoid it. Okay, yeah, so perfect example, right? Large fibroid, uterine fibroid embolization, you know, reduced it in size, now it's growing again. Bulk symptoms, right? Pressure, there's no more periods because you're postmenopausal. And then so estrogen, so potentially estrogen could stimulate the growth of the fibroid. If you do estrogen replacement, that's potentially can happen. But the question you have to ask yourself, so you're already having bulk symptoms now. So even if, let's say, this fibroid does not change, it doesn't increase anymore in size, it stops growing, would you be happy with the way it is now? So really, I think that's the biggest question to ask. If the answer is no, then I would probably take care of it now and just move on. You're considering surgery but want to avoid it. I mean, you know, I get it, but I think it just depends. If the recovery, think of it this way, recovery, so let's say it'll be, you know, 7 to 10 days. So let's say 2 weeks, but then you can just put it behind you and you're done, and you don't have to think about the fibroid, and you can take whatever HRT you want. Another point about HRT is that hormone replacement therapy, and this is sort of off topic, but just very quickly, a hormone replacement therapy is given for postmenopausal patients to control hot flashes, night sweats. There are two types. There's estrogen and progesterone, which is we call combination HRT, and that's given to patients who still have their uterus, because we cannot give estrogen only hormone replacement to patients with uterus because it could cause uterine cancer. The problem with combination HRT is that it does have a slightly higher risk for breast cancer. Okay, so that's been shown and proven in multiple studies. So if you want to have the option of safer hormone replacement and not worry about the fibroids growing or shrinking or what's happening, I would say get the uterus out, right? Do a partial hysterectomy, keep the cervix, and then you can safely use the estrogen only hormone replacement. You can use a low dose. You don't have to worry about higher doses and stronger things. And that, I think it would be, you know, a win-win. So I think about that. What is defined as a large fibroid versus medium or small? Yeah, so that's a good question too. I think it's, you know, it's kind of subjective, because, you know, to me, something that's, you know, large may be, you know, massive to other people, and small is, you know, very small to me. But I would say if it's less than 5 centimeters, or let's say, I would say one or 2 centimeters, that's very small, right? So you typically wouldn't do surgery for a fibroid that size unless it's in the uterine cavity, and then those have to be removed. So any size fibroid in the uterine cavity needs to be removed because it causes bleeding and it interferes with pregnancy. If you just have small 1 to 2 centimeter fibroids scattered throughout the uterus and the uterine muscle or outside of the uterus, that's probably not a problem, but you gotta keep an eye on it because they will get bigger. So small ones go to medium and then go to large. Medium size, 5 centimeters is medium, I would say, you know, 10 centimeters is large or above. But again, it's all relative. And I think, again, important to understand where they're located and what problems they're causing. So, and then, so yeah, the LAM is laparoscopically assisted abdominal myomectomy. So it's a minimally invasive myomectomy. Is it possible for large tumors to mimic sciatica? Yes. So sciatica, right, it's just pain radiating from the nerve in the spine down to the leg, to the back of the leg, and down your butt. Yeah, if you have a large fibroid pressing on the spine, it can mimic same symptoms, or maybe it can make your sciatica symptoms worse. I have family history of fibroids at a younger age, 30s. I've been experiencing a lot of pain, pressure, and pain that radiates down the right leg. Yes. It has begun to affect my quality of life. I'm active and the pain has increased. The hysterectomy in my near future. Well, let's see. How old are you? Depends on how old you are. I think is hysterectomy, it might be in your future now. I think, again, if you're already having symptoms, I think it's, you know, just, you have to be honest with yourself and decide, okay, I need to take care of it now, right? Because typically, if you're having symptoms due to fibroids, those symptoms are not going to spontaneously resolve unless you take out the fibroids or address the fibroids. So if these fibroids are truly what's causing the pain and pressure, then there's nothing, don't wait for the future. Okay, do it now. Maybe you don't need a hysterectomy. Maybe you could do a myomectomy, again, depending on how, you know, your age and kind of what the situation is. But yeah, I think, you know, life is short, right? Maybe and some patients or some people in general, you know, they don't know how long is their future, right? So I think it's best to just improve your quality of life today. Okay, so just yeah, don't live for the future, live for today.
That's, I think, Dr. D, I know we have about 10 minutes, so just in the interest of time, we have a lot of questions, but I also want you to get through your material here, and then we'll circle back onto these questions and address them.
Okay.
So
yeah, just the last one is the LAM procedure, numerous fibroids. Yes. there's not too many for lamb. Again, it just depends on the situation and the safety, the age of the patient, why we're doing this. But yes, you can definitely take out 30 fibroids with lamb procedure. All right. So lamb versus uterine fibroembolization versus Acessa. Again, it's important that lamb helps fertility, it removes fibroids, even if it's multiple, and helps the bulk symptoms. UFE doesn't do any of that, and Acessa doesn't do any of that either. So just keep in mind when choosing that option. Now, for patients who do not desire fertility, again, ideally, right, the best sort of least invasive, best recovery option is going to be a partial hysterectomy, all right? 2 small incisions, recovery 7 to 10 days. Again, less pain during that recovery process than a myomectomy. Also outpatient, so no hospital stay. We actually do, both myomectomies and hysterectomies out of the hospital completely. Better than Acessa and UFE, right? Because again, it's successfully treating so you get immediate results, not you don't have to wait a year to wait for them to shrink and all that. Immediate results, bulk symptoms and abnormal bleeding. And most importantly, this is definitive treatment. So a lot of times I see patients and they don't, they know they need surgery, right? So, okay, that's decided, but then they're not sure, should I have a myomectomy? Should I have a hysterectomy? Let's say they don't want fertility, right? And so they're considering both options. The biggest regret is to have fibroid removed only, and then those fibroids come back. And then you're back again talking about another surgery. So that's very important because fibroids do grow back, right? So if you're, let's say, I don't know, 42 years old, you have kids or you never wanted kids, and now you're thinking about, should I take out the fibroids only or should I do a hysterectomy? Maybe, am I too young to have a hysterectomy, right? So that's a very important point to consider, is that the fibroids will likely come back, and there's a very high chance that you're going to be needing another surgery or another procedure to address these fibroids. You can have your uterus removed in your, early 40s or even 30s. We're not taking out the ovaries, right? So the ovaries will continue to produce hormones. So you're not going to be in menopause. And then we also, most of the time, we keep the cervix, and that just helps preserve the pelvic floor, the integrity of the pelvic floor, and reduces any issues with intercourse. So there's no change in the vaginal length. Everything stays the same. The only thing we're taking out is what's inside the abdomen. All right, and to compare the 2-incision hysterectomy with other approaches, we found similar results to the myomectomy approach. So this was a study of 2,600 patients. Same thing. We took all the surgeries that were performed in the hospital, in one hospital within a 2-year period, and different approaches: robotics, standard laparoscopic, our dual port approach, and even vaginal hysterectomy. So we compared all of them and found that there was less bleeding, fewer complications, shorter operative time with the dual port approach. Again, if you're considering, you're telling yourself, okay, so I don't want the myomectomy, right? Maybe too invasive, to whatever. Should I just get Acessa or embolization, right? I don't want to get pregnant, it's fine. Again, important thing to remember, bulk symptoms. If you're having pressure, don't do Acessa or embolization, because most likely those symptoms are not going to resolve. If your belly is protruding, you can actually see and feel your fibroids, don't do embolization or Acessa. It's already too late for those procedures. And then, with fibroids, with hysterectomy, fibroids are gone forever, right? You won't have to think about it again, and you're solving the issue of abnormal bleeding. And then if you are postmenopausal, then, if you're already postmenopausal at the time of the hysterectomy, you can safely now use estrogen only without increasing your risk of breast cancer. So this is true story. Patient from out of town, 46 years old, right? She had a UFE in 2022, uterine fibroid embolization. This is actually a little cutout from her MRI. So she had an MRI in March, and her uterus was 29.4 centimeters. So it's about 11.4 inches which is like a watermelon. She had 2 large fibroids. One was 16 centimeters, so very large, kind of on the outside of the uterus, and one big fibroid in the muscle of the uterus. She did another follow-up a year after her embolization, so now in 23, and fibroids, the 2 large fibroids had not changed in size, and then she had a couple of small ones that were new. So she was recommended to either have a hysterectomy or do a second embolization, which is, to me, is like insane. Why you would do that again? And she, thankfully, she thought that did not seem rational either. And when she went to her, OBGYN, they said, sorry, your uterus is so big, you can only have open surgery. So she was looking for a second opinion, ended up coming to Maryland, had a laparoscopic supracervical hysterectomy. So we took out the uterus and the fallopian tubes. We kept the ovaries and kept the cervix, and she did great. This is what everything that came out. So everything is already degenerated, because of the embolization, cut off the blood supply. So it's kind of dead tissue. That's why it looks so dusky. This is a 6-inch ruler. This is a little cutout from her pathology report. So it's a weight in grams, which is about but it's 5 pounds. And this is, I thought it was interesting because, so these little beads are actually the particles from the embolization. And these to me look like Mardi Gras colors for some reason. Like as soon as I saw it, I was thinking about king cake, but yeah, so that's super bizarre. But, and also on pathology report, they found the embolization particles in her fallopian tube. So that means, that tells you that, they do end up outside of just fibroid tissue. So just something to keep in mind. It's not dangerous, but it's just a matter of effectiveness, and again, affecting the blood supply to the ovaries. So conclusion, be your own advocate, right? So you just have to, don't worry about, feelings, or that you're going to hurt somebody's feelings. And I understand that a lot of you may have an OBGYN that you've been with for years. Maybe, he or she delivered your babies. So it's not a matter, it's just recognizing. And I think if that doctor cares about you the way you care about them, they will understand, and they'll recognize that, okay, now it's time for a specialist. And they would do the same. I can promise you that. I've had, multiple colleagues, OBGYNs, who, referred their family, and close friends to me for surgery, but yet, didn't do that with their patients. So make sure that you ask questions. Will this procedure address all of my symptoms, right? So if you're going for uterine fibroid embolization, find out what is the likelihood that all of your symptoms are going to be addressed. I mean, you don't want to go through any procedure or surgery if you're only taking care of one problem and leaving 5 other problems in place. And then ask, is this procedure the best if I'm trying to get pregnant? Don't ask, is it safe if I want pregnancy? Because they're probably going to tell you yes, and they've been patients who gotten pregnant and they were fine, but that's not the issue. Is it the best one for me, right? What is the likelihood of me needing another surgery or procedure in the future? That's very, very important, right? If you're looking for definitive treatment, then don't do, embolization, don't do myomectomy either, right? Because that's not gonna once and for all take care of the problem. And then if your doctor is not able to do minimally invasive surgery for you, ask them to refer you to someone else or do your own research, right? So they're almost, I would say, maybe the less than 1% of the time that a patient is truly not a candidate for a minimally invasive surgery. And that's typically, if let's say someone who's had prior surgeries that they have a lot of scarring, they have very, very, very large fibroids, so kind of an extreme, right? So in some 90th or 99th percentile of fibroid size, but they only want fibroids removed and not a partial hysterectomy. Then in that case, sometimes I will say, listen, do I think a myomectomy is the right procedure for you? No, but I think if that's what you really want to do, probably the open approach would be the best, because it's just, there are too many risks, the way I see it. So that may be, but that's extremely, extremely rare. 99.9% of the time, patients are absolute candidates for minimally invasive surgery.
Thank you so much, Dr. D. This was
Sure.
amazing. And oh my goodness, we have such an interactive group here. So just to answer some like umbrella, like a lot of questions that I've seen in terms of consultation, I'm sharing a link. So if you're interested in scheduling a consultation, you can use that link to schedule a consultation. We do have locations in New Jersey, and here in Rockville is where we perform the surgeries, but we have one in Reston for consultation as well as in New York for again. So several locations for consultation, use that link to schedule. Also, I'm going to share an evaluation form here. Please take a moment to complete that evaluation. It helps us really tailor our educational programs. So make sure that you complete that. We do have, although we're right at the time, we have several questions. So stick around, Dr. D. I'm going to ask you for about 15 minutes of your time so we can start with Hope's question. Right, if you scroll up, you would see Hope is where we can start, and we can go through those questions. And if we don't get through all of them, we'll try to get them to you, an answer to you via our follow-up. In the follow-up, you would get the recording from me as well as the PowerPoint presentation. So you'll have these resources at your disposal. All right.
Okay.
Dr. D.
Yeah. So
turning it back to you.
Yeah. So just to address Michelle's question. So yeah, definitely, it's fine to do myomectomy. If you're trying to conceive, I mean, any surgery could potentially affect fertility. So it's very important. I don't want to make it sound like surgery is without risk. So scar tissue can form on the uterus, to the uterine cavity, to the fallopian tubes after removing those fibroids. And we typically recommend checking for scar tissue 6 months after the surgery. So at 6 months, the uterus should be fully healed, and then we assess for scar tissue. So some of it is inevitable because let's say there's just a ton of fibroids, and that's why delay in care is so detrimental, for many reasons. It makes the surgery much more complicated, and it can increase the risk of scarring post-surgery. But if you have fibroids that are interfering with fertility, again, here the benefits would outweigh the risks, and I would say you have to have those fibroids removed, and just do it by a skilled surgeon because there are lower complications in that case. Endometriosis. So Hope, I have endometriosis, had 2 surgeries last year while being treated for infertility, and the fibroids are back already. Unfortunately, I had to go to the ER 2 weeks ago with severe pain, had ultrasound, which confirmed more fibroids. Now they believe I have endometriomas. So, what treatment options are available? Yeah, I mean, the fibroids can come back. I think it also depends what type of surgeries were done. What I've seen before is that as a patient's trying to get pregnant, an OB/GYN, they do an ultrasound, they see multiple fibroids, including a fibroid in the uterine cavity. And they say, let me just go back to the picture. And they say, okay, well, you have multiple fibroids, but since you're trying to get pregnant, let's just address this little fibroid. Can you see me on the screen? Yeah. Let's just address this little fibroid. And what happens is that they just shave off a little bit of it, and then it's still there. So you're essentially keep having the surgery on the same fibroid. It's not that fibroids are growing back, but also it could be that, yes, you had surgery in the past, let's say 5 years ago or more, and still trying to get pregnant 6 years later, and now fibroids are back. Unfortunately, those fibroids again need to be removed. You can do the LAM procedure, again, but with each additional surgery, there's more potential scar tissue. So that's why it's so important to choose the right technique the first time. So if you had, let's say, robotic myomectomy, and they took out the external fibroids, which are large, and left the smaller ones inside, those smaller ones grew. So now you're having repeat surgery for really the fibroids that were just never removed in the first place. Endometriosis, absolutely. And we see, at least 50% of the time we see endometriosis at the time of the fibroid surgery, and we'd remove it at the same time. So you wouldn't, What advice would you give a patient to treat? Yeah, you wouldn't treat one thing first and then the other, right? You would treat everything at the same time. You've got to address endometriosis and you have to address fibroids. Also, I don't know the background in terms of fertility and what fertility treatments have already been done. But if we're talking about 6 years of infertility, probably we're talking about now IVF. So I think you need a skilled surgeon to take a look, at all the imaging and kind of, endometriomas probably need to go if they're sizable. What happens regarding multiple fibroids, embolization? So patient who is 50 had embolization and been told that she had another one, she could go into menopause. She was told the other option would be hysterectomy. She doesn't want, still having periods and still has a desire to have a child, if she believes it's nature that decides, just want to remove the discomfort with the least invasive surgery. The largest is 10, but there are 20 plus fibroids. Yeah, that's a tough one. Okay, because so we're talking about now numerous fibroids, right? Probably large uterus overall with that many fibroids, with the largest being 10 centimeters. So this is again where we're talking about safety versus risks versus benefits, right? So because we know that at the age of 50, the chance of spontaneous pregnancy is extremely, extremely low. So it's probably close to zero. Then if we know that the risks with myomectomy are very, very high, then it's probably not a reasonable option. Okay, especially again, since embolization has already been done, already makes it even puts another layer of complexity to the whole situation. Sometimes we do myomectomies on patients who are, in their late 40s because they're trying to do a donor egg IVF. So that becomes, more reasonable option because with the egg donor, the chance of pregnancy is going to be higher. Another thing to keep in mind, though, so let's say if we're talking about somebody who's not 50 but 30 years old, right? So realistically, with removing that many fibroids, what is the chance of the uterus healing? So that's another risk, right? Of, again, delay in care where you have the more fibroids you have, the bigger they are. While we can do the surgery, what is the chance that there's going to be still a healthy uterus remaining? So again, the risks of scarring are pretty high with any technique, just based on the fact that we're taking out that many fibroids. So there's very little normal uterine tissue that's already there for us to work with. So that's what makes it very difficult. Long-term use of birth control. I mean, birth control pills are very low dose, right? So, I mean, again, we're talking about something potential, but remember that ovaries are still producing a lot of estrogen. And let's see. So yeah, so we're located in Maryland. So if you want to do a phone consultation, we're definitely available. Diet, does it play a role in managing hormonal triggers? So we talked about, right, certainly anti-inflammatory diet can help deal with some of the symptoms. But if we're talking about not having, not stopping the fibroid growth, that's going to be very difficult. Online consult, yes. So if you've submitted something, that someone will definitely get back to you.
You can move on to Lisa's question. Most of them are about consultation.
Okay. Yes, yeah, so it's confusing. So the LAM is just for fibroid removal, and the dual port is for uterus removal. And then we talked about how it differs from other. It's just a fewer complications. It has shorter recovery. It can be safely done on outpatient basis. There are fewer incisions. It's a quicker surgery, so the operative time or time under anesthesia is going to be faster. Okay, why don't regular GYN checkups regular sonogram? Yes, I agree. So the question is, why don't regular GYN checkups do regular sonograms, since fibroids cannot all be detected during regular pap smear? Thank you. Yes, that's I know, very good question. So, you know, if we do mammograms when you're 40, or, you know, so we're checking for breast cancer. Why can't we do ultrasound to check for fibroids in someone who is a high risk patient? We absolutely should. I think, yeah, you can definitely ask your OBGYN to do a pelvic ultrasound. You know, just say you have family history of fibroids. Don't tell them I told you to say that, but make something up. But yeah, it's if your OBGYN is very resistant, you know, which they probably won't be, so you can definitely ask for a pelvic ultrasound. How do you check for scar tissue? So we do what's called an HSG, hysterosalpingogram. It's an X-ray with a dye that checks for scarring to the fallopian tubes and uterine cavity, and that should be really done with everyone who's trying to get pregnant. But yeah, don't worry if your surgeon did not check for scar tissue, that could still be done. So it's not too late. Oops, something happened. Oh, okay. My fibroid is large, 11 centimeters. My OBGYN said I don't qualify for laparoscopic surgery, but for open, is this true? Yeah, it's not true. So again, you know, your OBGYN is going to tell you things, what they're capable of, right? So if that OBGYN does surgery, but they have a limitation, they're going to say, no, your fibroid is too big. Just get a second opinion, okay? If they're kind enough, they may give you a recommendation, but sometimes they might just say, no, you're not a candidate, and that's it. So just, yeah, you can definitely talk to us, but just get a second opinion. 11 centimeters is not too large to do it laparoscopically. So LAM is faster, but it's a myomectomy procedure, and I hear that it's more risky and harder than a partial hysterectomy. Is that correct? Yes. So yeah, so exactly what I had said earlier. It's any myomectomy, whether it's LAM or something else, it's a more technically difficult and has more potential complications than a partial hysterectomy. Now, we're not talking about when it's just one fibroid, but if it's multiple fibroids, or very large fibroids, a partial hysterectomy is always going to be a safer approach, for sure. And it's going to be an easier recovery. So if you're on post 50 and in menopause, forget about the myomectomy. I think it's not going to be the right approach. It's not going to be beneficial for you. And you're going to do much, much better with doing a partial hysterectomy. And again, you're keeping the cervix, keeping the ovaries if you like, although you don't have to because you're already postmenopausal, and you're going to be very happy.
I think, Dr. D, this might be a good time for us to pause.
Okay.
The questions that came up after that is something you've addressed already. So what I would say is that I will share this recording, and I will, you would have some of these questions answered. She's gone through some of them already. I want to thank you all for sticking with us, and we hope you found this as informative as I did. I'm always learning from Dr. D here, and the questions were just wonderful. Thank you for being an engaging group. We do these almost monthly right now, so be on the lookout for our next educational session. I also am going to encourage you, we do a little tidbits of videos on our social media, on our Instagram, on our TikTok, on Facebook. So we do little informational sessions with Dr. D. So follow us there to get some more information. So encourage you to also check out our website if you need any resources. Our website is filled with a lot of resources, patient stories to the techniques, deep dive into the techniques Dr. D talked about. So I want to thank you all for being such a gracious and wonderful audience. And I especially want to thank Dr. D for being a wonderful speaker here. So thank you all, and I hope you enjoy the rest of your day, and be sure to complete those surveys, please. Thank you.
Thank you. Bye.
Bye.